For those of you who are here, thank you so much for joining Avestria's first Women's Health webinar of 2024. I'm Ava Epker, I'm the Director of Marketing, and you'll meet the rest of the Avestria team, as well as 2 members of the Axena team throughout the webinar. This webinar features Eileen Maus and Dr. Mandy Pulliam from Axena Health to talk about pelvic health. So we're really excited for them. We're really excited for those of you who can join us. And just a reminder to please put questions in the Q&A box or in the chat box. We will see them and we'll be able to ask our panelists during the end of their presentation. And if you cannot make the whole webinar, don't worry, we'll put the full recording on YouTube and send you a link. So thank you for joining however long you can join, and I'm going to pass it off to another member of the Avestria team, Linda, to give you an introduction.
Thanks so much, Ava. I'm Linda Grube. I'm co-founder of Avestria Ventures. We're based in San Francisco, and we were founded in 2019. And what makes us a little bit unique in the venture capital community is that we have healthcare operating backgrounds, and we have extensive industry networks. My partner, Tracy Dooley, and I have known each other and worked together really since 2010. Ava, our director of marketing, I've known for 20 years, and Michelle Branch, who is our legal counsel, we've known for decades as well. So we all know each other, respect each other, and have a lot of fun working together. Next slide, please. In terms of what Avestria Ventures does, we invest in early stage companies that are working to improve women's health. And we define women's health as conditions that affect women exclusively, disproportionately, or differently. So exclusively reproductive health, menopause, but disproportionately are things like Alzheimer's and autoimmune disease. And then differently, cardiovascular disease and oncology are 2 great examples. Cardiovascular disease is the #1 killer of women, and yet women are misdiagnosed a lot of the time because their symptoms are different from men. In terms of what subsectors we invest in devices, diagnostics, digital health, life science tools, services, and therapeutics. We do not invest in direct to consumer because that's a very different market, and it's really not our background. And then Tracy, who went to Stanford Medical School, will talk to you a little bit about the background on research in medicine.
Yeah, so thanks, Linda. I think that we've seen that I'm not going to read you this slide, but we feel that there's absolutely a disproportionate amount of funding being deployed to these conditions that affect, largely over 51% of the population. But women and men are very different from a biological cellular basis, but primarily medicine and research and science have been based on research on men. And we can see that, as women have continued to be able to participate in clinical trials starting in 1993 and now increasing more, we're seeing that there's more and more insights that we're gaining, but there's still a long way to go. And there are serious unmet needs in all of the therapeutic areas that Linda had mentioned previously that we currently understand. There's a difference there. But we still are seeing that the funding, both on the public side from the NIH or public and private R&D funding from startups or pharma or venture capitalists, is really going to be directed towards women's health. But that being said, we are also seeing that there's a significant market opportunity here, because in the past couple of years, we've seen that women's health has become more and more well understood, right? And there's been more recognition. These are still small dollars overall, but we're fortunate that in 2021, it sort of broke the $1 billion mark as far as deployment into women's health investments from venture. And obviously within the overall healthcare ecosystem, looking at a $4 trillion market with significant growth, there's a lot of opportunity to improve this and to move forward. So we're really grateful to folks like Eileen and Mandy, who are doing incredible work to change outcomes and deliver really real improvements in care for patients. So with that, I will turn it back over to Linda to introduce.
So we were very fortunate to have the opportunity to invest in Axena Health last year. And today we have Eileen Maus, CEO, and Mandy Pulliam, the Chief Medical Officer, to talk about Axena. But also we've asked Mandy, because of her background as a clinician, to begin by talking about the need that they're trying to solve. Mandy is joined Axena in 2023 as its Chief Medical Officer. She was previously Chief Medical Officer of Renovia, where she directed clinical research and this, including the successful completion of an all-remote clinical trial using Leva, which is the pelvic health system, which Axena offers during the global pandemic. Mandy was also the Division Director for Female Pelvic Health at UNC Chapel Hill, Associate Director of Female Pelvic Health at Mass General, and past Council Chair for the American Urogynecological Society. Mandy received her Bachelor of Science degree in biology from Duke and her medical degree from Wake Forest University School of Medicine. She completed residency training at Brigham and Women's and fellowship training at Mount Auburn Hospital in Boston. She is board certified OBGYN and female pelvic health. So Mandy will begin, and then Eileen brings 20 years as a healthcare industry sales and marketing executive with strategic planning experience to her role as CEO of Axena Health. Eileen entered the women's healthcare space during her 12 years with Cytec Corporation, where she helped grow the company from 8 million to over 700 million and managed sales forces for 5 new product launches. Prior to Axena, Eileen served as CEO of Renovia, the medical device company who developed and first commercialized the Leva pelvic health system. Eileen is a graduate of LaSalle University with a Bachelor of Science in Marketing and Communications. I just want to say that it's such a pleasure to work with Eileen and Mandy. They are just, not only are they incredibly bright and really experienced, but they're just really kind, wonderful people. So with that, Mandy, we'll let you start.
Okay, thank you very much, Linda. I appreciate it. So my role as a clinician, and actually I work with Axena Health, and I also practice several days a month in Boston, which is actually what I've come off of just today. And so I'm looking at these numbers that I want to tell you about and realizing that they are sort of the tip of the iceberg in explaining women's experience with urinary incontinence. But the truth is that the number of women in the United States that have urinary incontinence is pretty staggering, 78 million women. And only really a small fraction of those women, 11 million, are seeking treatment, right? So these are some of the women that I saw yesterday and the day before. Of the 78, most women manage their urinary incontinence with pads or diapers, or maybe trying some pelvic floor muscle exercises on their own, or maybe they don't do anything, commonly thinking that this is just something that happens because they're getting older, or something that happens as a result of childbirth that they can't do anything about, or at least they would need to have surgery or something major done, and they don't want to do that. So many to most women appear at the doctor's office for their OBGYN appointment, maybe their well woman appointment. And they are first identified as having urinary incontinence in that context, most often because those 11 million women tell the doctor, and maybe sadly rarely because the doctor or the nurse practitioner or the PA asks about urinary incontinence. So of those women, even though they get a diagnosis of urinary incontinence, over a third of them, right from the beginning, don't do anything. They wait. Perhaps they're told by their clinician that things will get better, and so they sit and experience urinary incontinence and all of the things that are associated with it, like obesity and inability to exercise because of leakage and depression and social limitations, and they wait, even though there's a really clear care pathway for what happens for women who have a diagnosis of urinary incontinence. In other words, there's something to do. The challenge is that the something to do is actually sort of difficult. And you can see this difficulty for both clinicians as well as patients. So here on the screen is the care pathway. This is what's supposed to happen with women who raise their hand and say, I have urinary incontinence. There are 2 major kinds: stress, which is leaking with coughing and sneezing, and urgency, which is the feeling that I have to hurry up and go to the bathroom or I'm going to leak on the way. The first line treatment for all types of urinary incontinence is pelvic floor muscle training, right? So that is strengthening the muscles that hold the bladder closed. And that can happen with supervision or also biofeedback. But what we see in terms of who gets pelvic floor muscle training as the first thing to do is that amazingly few women who raise their hand and say, I have urinary incontinence, actually have pelvic floor muscle training as the first thing that they're asked to do or assigned to do by their clinician when they're diagnosed. I think only 6 or 7% of women are sent to pelvic floor muscle training with a physical therapist or with someone else or at home with information about how to do it at home. And of those women, we know that for the physical therapy group, only about 1/3 of those women actually complete their therapy. Many more, up to 1/3 of women, are instead given advanced treatments like pessaries, which is a wearable device in the vagina, or medications to treat their urinary incontinence. And this is unfortunate in part because medications, for example, have some pretty significant side effects, and also you have to take them for the rest of your life for a problem that's not life-threatening, it's just life-altering. And then another significant proportion of women are actually sent to undergo surgery or an injection with something like Botox to treat their urinary incontinence. Those are treatments that should be reserved for women who can't be treated with first-line therapy, but who can instead move through and have kind of tougher to treat urinary incontinence. But they go right to these treatments as the first thing. And you might ask, why is this? And I'll say from seeing patients, just even in the last few days, I think there is a mystery about pelvic floor muscles. When I perform an exam on a patient, if I ask them to squeeze their pelvic floor muscles, very often they're unable to do so. And so if I ask them to go home and exercise, it's sort of asking them to go home and do something they don't know how to do. And they're not sure if they're doing it properly. The reason for that is you can't see those muscles, right? They're inside your pelvis. And unlike your bicep, say, you can't look and understand if you're using it properly. And so I think there's a hopelessness among women who are sent home to do these exercises without any type of opportunity to know if they're doing it properly. And that, I think, feeds back to clinicians who think, maybe this will help, maybe it won't, probably not. But the truth is, the data tells us that it does work. Women just need an opportunity to do it and do it properly with confidence. And that's where Leva comes in, and we'll talk about what we've been working on to address this problem for women. And women come in and they're concerned, right? They're concerned about their urinary incontinence. It's altering their life and the things they can do in their life, ranging from playing with children if they're younger women, to being out with friends if they're in a different kind of time in their life. But it affects women across the lifespan. And here, this little picture on the right of this screen shows that from ages 20, when maybe 4 in 10 women have urinary incontinence, which is a lot of women. And as you get older, by the time you're 50 or 60, more than half of women have urinary incontinence. So very common, very under-addressed, and easily addressed with the right opportunities for women to perform this first-line treatment for urinary incontinence. What we know about first-line treatment is that if done correctly, it could prevent at least 50% of surgeries and other greater interventions that may happen down the line for urinary incontinence.
So I just do want to address the question in the chat, or the comment in the chat, about women in France having pelvic floor therapy available to them after they give birth. And that's true. France is much more advanced than the United States is with their focus on pelvic floor physical therapy. And we applaud France and, hope to follow in their footsteps, that women in the US are treated to that same ability to recover their pelvic floor muscles after giving birth as
Right.
they are in France, because it's really needed and necessary.
Right. And I think childbirth is one of the first things that happens for a woman that really can cause urinary incontinence. Many women who've never had a baby also have urinary incontinence, even and as in younger women, athletes and so forth often experience leakage. And then a second kind of hit, if you will, to the system is at menopause, when again, women who may have had what they consider to be manageable incontinence or no incontinence begin to appear at their doctor's office in their 50s because they're now leaking.
If you think about why it's so important to get treated postpartum or as you go through menopause is that because the symptoms do worsen over time, and women who've had prior UI, for example, after giving birth, have 25 times greater odds of having a recurrence of urinary incontinence. And I think we're all aware of the negative quality of life, reduction in physical function, cognitive performance, and associations with obesity, depression, and anxiety that comes from having such a condition that influences your ability to go out and socialize and to exercise. It's actually the #2 reason why women are admitted into nursing home is incontinence. And I just think, you know, it's the only lie our grandmom ever told us that leaking is normal. It is very, very common, but in the year of 2024, it absolutely should not be normal. And we have a product that can address that for the women that suffer from it. And if we go back to the care pathway that Mandy was talking about, with so few women able to take advantage of first-line therapy, most skipping right to medications or to surgery. And even if we do get women into those first-line or second-line medication, the discontinuation rates are really high. So a very low percentage of women actually get to a first pelvic floor physical therapy appointment, and the discontinuation rate after a series of 3 treatments is about 30%, and about 50% of women on medications for overactive bladder discontinue within the first month. So you can see we have a red hot mess going on out here in how we address this problem that affects so many women. So Leva was designed with these limitations of current first-line treatment in mind. So what are the concerns? There's a limited number of pelvic floor physical therapists that are available to treat women, and there's long wait times to get into those appointments. So wait times in certain metropolitan areas can be 2 to 3 months. With 2 to 3 months, you could be completed your course of Leva therapy. Time constraints. If you're working or you're a mom, the ability to get out and get to appointments is very hard for most women to do. Supervised pelvic floor physical therapy is an internal exam, and it's invasive, and many women are uncomfortable with that. And there's financial constraints. Most pelvic floor physical therapists, about 80%, are out of network. So women are paying out of pocket for that therapy. So how do we address the limited number of PTs that can perform this skilled therapy? Leva is done at home. It's individualized for each patient, and it can be used from anywhere. So we take really those best practices that pelvic floor physical therapists have, and we incorporated them, taking advantage of what technology has to offer. Women do their Leva therapy. It's just 2.5 minutes twice a day. That's a total of 5 minutes, and they do that for 12 weeks. And with that regimen, we have about a 72% adherence to the therapy. It is discreet, non-invasive, and women get feedback that they're doing their pelvic floor muscle therapy correctly and consistently. And when it comes to financial constraints, we're absolutely dedicated to producing the clinical data and the support that's needed from societies to have Leva covered by insurance. We have coverage from national and regional insurances. It's also covered by FSAs and HSAs. And we provide background checks, benefit verification, and prior authorizations. We don't need to get that much into your personal life. We don't do background checks. We do benefit verifications for all patients that are provided a script from their clinician. So what is this great technology that we're talking about? What you see on the left-hand side of your screen is the vaginal wand, and you see that cross-section with the green dots are accelerometers. And what they allow you to do is, if you think about your pelvic floor, it shows your pelvic floor in relationship to the earth. So if you're doing pelvic floor muscle therapy, what you need to do is lift your pelvic floor up and towards the pubic bone. The vaginal wand resets for each woman's anatomy. So you're able to visualize the movement that you need to do. And you go through, if you look on the right-hand side, a series of relaxation exercises to reduce or relax all those muscles. And then you go through that. Of course, now it stops working when I say go ahead and look at that. So I'm going to start over from the beginning of here. Leva is done in the standing up position because that's how your pelvic floor bears load. Then you're going to go through a series of relaxation exercises. You can see this woman has problem relaxing completely. And then you begin the lift. This was a strong, healthy woman that did this pelvic floor lift or Kegel, and you hold that for up to 15 seconds. And most women, when they start therapy, can not raise the bar that far, nor can they hold it for 15 seconds. But as they go through the course of therapy, you get stronger and you're able to hold it longer, which is why we have the clinical data that we do, that your pelvic floor begins to function as it should, and you use it every day. As we're all sitting here or standing right now, we're engaging our pelvic floors. And we actually wrap the Leva system in a support, we wrap it support around it. So you saw the vaginal wand and the smartphone app. So just 8 weeks of using Leva is going to give you 2 years of improved symptoms. In the app, there's a variety of adherence monitoring. There is celebration for hitting your milestones. The same validated surveys that were used in our clinical trials to track symptom improvement is embedded in our app. And a woman is also given educational materials so she can understand whether she has fecal incontinence or urinary incontinence. She will be provided with information to help her manage the condition. We also have a coaching team. So when you start on Leva therapy, that you're provided with a coach who interacts with you the way you want to be interacted with. If you want to have live conversations, she'll do that. If you'd rather just text back and forth or send emails, really happy to interact with you however you want during the course of your therapy. We also provide, whichever clinician ordered Leva for you, a report every 4 weeks as you go through your therapy to let them know how you're doing and how your adherence is and how you're progressing against your goals. So if you're one of those women that needs to go on to second and third line therapy, then your clinician is aware of that, and you can get, we don't want you to try something and then stop, right? We really want an improvement of your symptoms and improvement in your quality of life. So we keep the clinician involved. So in case you need to go on to additional therapy, they're there right away, and they can get you into a urogynecologist like Mandy or into second or third line therapy. We do have patents around all the technology, and the price, whether you're a patient paying out of pocket or to insurance, is $1,200. And why did we design the system the way we do, that you do it 2.5 minutes twice a day while standing for 12 weeks? Because if you look at Cochrane systematic review of all the data that supports pelvic floor muscle therapy, they say there's high certainty evidence that undertaking pelvic floor muscle training can cure symptoms and improve the quality of life for all types of urinary incontinence. That's why it's the first line treatment in the treatment pathway, because there is overwhelming evidence to support it. And the evidence also says that for pelvic floor muscle exercises to work better, if they're more intense, so that's 2.5 minutes twice a day, have support from a healthcare professional, which is why we keep your clinician in the loop, and have strategies for continued support, which is why we have the learning and education that's built into the app, as well as a coaching team. So when you put all this together as a package for women, you get really strong clinical results. And Mandy, since you're still here, do you want to talk about your clinical results?
Sure. One thing that's very important to us at Axena is that we provide products to women that have been proven to work and have been shown to work in well-designed clinical research. So on this slide, there's information about our randomized controlled trial. This was a 350-woman trial. It was conducted all during COVID. So women performed either pelvic floor muscle exercises or used Leva to do those exercises at home. And they performed their exercises, in this case, for 8 weeks. And then we followed them out to 1 year and 2 years after this initial exercise period. What we found was that at all time points, women who used Leva to perform pelvic floor muscle training had superior results to those who did exercises or Kegel exercises at home alone. What we found was that women using Leva had a significant improvement as early as 4 weeks, and that superiority continued at the 8-week time point, which was the end of the initial exercise period. And then when we assessed them again at 12 months and then at 24 months, at both time periods, not only was the improvement sustained, it was also superior to Kegels at all of those time points. In fact, Leva users were 2.5 times more likely to have improved symptoms versus the women who did Kegels. And this was regardless of initial symptom severity. It was regardless of body mass index. It was regardless of age. What we have here then is durable evidence that shows that initial exercise using Leva lasts for at least 24 months. To confirm the survey results, we used a patient-reported outcome because the bother of urinary incontinence is important. We also looked at a bladder diary. This just counts the number of incontinence episodes a woman has on any given day. And what we found was 80% improvement in bladder diary results, which was significantly superior to the Kegel arm. So we've just published these 3 papers, the initial result, 1-year and 2-year results in support of what Leva can do for women. And we're really excited about this data because I think it confirms what we actually see with our patients on a day-to-day basis, which is that Leva improves their urinary incontinence and gives them back their quality of life.
So having this level of data is important, really important for 3 reasons. As women, we deserve to have clinically validated treatment. For physician adoption, they want to make sure that a product that they're prescribing for their patients has been well researched and will work for patients and is safe and effective. And number 3, the third leg of the stool is for insurance coverage. And I thought I would dive in a little to how the insurance process works for those of you that luckily aren't intimately familiar with it, and just show you all the work that goes into being ready to be in front of payers and to get coverage. So the product was cleared in 2019. The first study that Mandy was talking about, the original RCT, was published in March of 2022. We also had to document and publish health economic studies that look at what is the cost of doing nothing, or what's the cost of the current way of caring for patients. They were published in 22 as well, and a budget impact model was developed. So when having conversations with insurance companies, kind of have to look at what they're currently paying for, and does what you're asking them to cover for patients cost them money or save them money. We applied for coverage in the pharmacy channel and were granted that in 2022 as well, as we developed or worked with the American Urogyn Society and the National Association for Continence to write letters to the insurance companies in support of Leva. We had real world data published in August of 2022. So people say, hey, it's great how a product works in a clinical trial that's pretty regimented, but how does it work when you and I are using it in our everyday lives? This is the newsflash, works just as well. And we published that data in August of 2022. About this time last year, the 1-year follow-up data that Mandy discussed was published. And a month later, in an off-cycle review, Cigna adapted their policy to include Leva and covered Leva by name in their policy for urinary incontinence. We've had over 1,500 MDs write for Leva. In August of this past year, we implemented a prior auth and appeals process. So say you have United Healthcare, which doesn't have a policy whatsoever for urinary incontinence. We asked your provider for your insurance card and your clinical notes. We submit that to United and ask them to pay for coverage of Leva. We did apply, this is really grinding the sausage here, but for a HCPCS code, so a code that speaks specifically for Leva, and we were granted preliminary approval for that code in November of 2023, and that we should get the final wording on that code in the next couple weeks, depending no government shutdown, and that goes into effect over the summer. And just Monday of this week, our 2-year follow-up data from the original randomized controlled trial was published. So you can see a list here of some of the plans that we're going back to now that we have the 2-year data, asking them to cover Leva and to support Leva. I know there's a question in the chat, so I'm going to try to Oh, is the product approved by Medicare for reimbursement? The answer is no, not yet. Medicare is actually going through a lot of a lot of deep thinking about how to cover a category like digital technologies. I will say our average patient age is age 51. Although we did have a 91-year-old patient start therapy just last week, and we're excited. We certainly have many patients in the Medicare age that do take advantage of Leva. A lot of those use an FSA or HSA or pay out of pocket. We have monthly payment plans to help those women be able to move forward. I just wanted to show you, I won't go into too much detail, but just a look at what some of those health economic studies look like and where they were published. And it just really talks about what we already talked to you about women who have UI have significantly higher medical cost overall than women that don't, that the adherence to the guidelines is not good, and that pelvic floor physical therapy, which most insurance plans cover, is not just really accessible to most women. So great that you cover it, but very few women can make their way to pelvic floor therapy. This is a look at a cost economic model that we do for insurance plans. We look at how many covered lives they have, and if they just had a 25% adoption of Leva, what savings that would look like, and if they had 100% adoption, what those savings would look like. So we just kind of break down the economics. And for what it's worth, it's a win for the insurance companies to cover a product like Leva. It actually, not only are they doing the right things for their members, but it saves them money in the long run. I wanted to show you what some of our policies look like. Cigna, as I mentioned earlier, covers Leva. They call Leva out by name in their policy. That's fantastic. We also have a positive tech assessment by Horizon, which is Blue Cross Blue Shield of Pennsylvania, and they have you go through a tech assessment and then they write you into policy. And I'm sorry, Highmark did the positive tech assessment, and Horizon just updated their urinary incontinence policy to cover at-home treatments that have a treatment plan dictated by the physician. And again, on the right-hand side is the HCPCS code that we applied to for CMS. Even though we didn't apply for Medicare coverage, they are still the keeper of all the codes. It is a payer-only code that they recently approved for us. And just giving you, I'm checking the chat because I see a question there. Oh, Mandy, that was just Mandy dropping off. And any questions you have for her, we can get to her. Just wanted to give you a little bit of insight into our commercial strategy. So we have 5 reps calling on territories, mostly along the East Coast and a little bit in the Southwest. We put those reps in territories where there is a lot of Cigna, and our plan was to influence other payers like we've been able to do with Horizon and with Highmark. Just a little bit about the success Leva that has had this year. We began distribution in Q1 of this year. We launched our commercial territories in Q2. We began shipping Cigna in Q3, and we had real nice growth in Q4, about 60% increase in revenue as we really got our prior auth program up to speed, and our reps having great conversations with clinicians about how important it is to offer Leva to their patients. And this is just a look a little bit about the number of prescribers that are prescribing Leva month over month. They've grown about 20% month over month. We had about 555 different HCPs, and primarily for us, that's OBGYNs, nurse practitioners, physicians assistants, and certified nurse midwives. Once they hear the story of Leva and the success that their patients have, what we see on the right-hand side is they begin to not only write Leva for more and more patients, but actually begin screening. So not only being able to help the 11 million women that are raising their hand asking for help, but also screening the patients that are there for the one-woman visits. Many women aren't aware that there is anything they can do for urinary incontinence, or they think surgery is their only option, so they don't want to move forward with surgery. So there is a fair amount of education from the clinicians once they get past the women that raise their hand to letting their whole patient base know. So just to look at our prescriber growth quarter after quarter, and most of our prescribers that get started writing Leva continue to write Leva, and that's exactly what we want them to do. And I don't know if you want to go into our fundraising, but I certainly wanted to give you a little bit of highlights about what we accomplished in 2023. We talked about the positive insurance coverage decisions, setting up a distribution network, the publication of our data. We did get an indication for fecal incontinence that was we launched in Q2 of last year. We do have a low and middle income country strategy. So we're working in sub-Saharan Africa to bring some version of Leva to them. What we're looking for 2024, we're thrilled that the 24-month data was published. We're looking for additional coverage. We submitted additional real-world data for publication. Just yesterday, we submitted for an indication for pelvic organ prolapse. So that'll work its way through the FDA, and we hope to be able to market to that in the second half of the year. Just a little bit look at our forecast going out for this year. We'll do about $6.6 million in revenue this year, and we'll hit break even in early 2026. So in conclusion, terribly, an awful lot of women suffer from pelvic floor disorders. It's a tremendous market opportunity for investors. Product is really differentiated and FDA cleared for urinary incontinence and fecal incontinence, and a pipeline of future indications like pelvic organ prolapse. We have proven efficacy, a great commercial team calling not only on clinicians and calling on payers as well. We're working our way through the reimbursement pathway, and we're just really excited to have this product in the market so women don't have to carry around a change of clothes with them. They don't have to be embarrassed, that they can treat the condition and go on and have a happy, healthy life. So I will stop sharing and happy to take any questions.
So for everyone who's on the webinar and has a question for Eileen, please put it in the Q&A box. We also have a few questions to get started, Eileen. So the first one is, what if I contact my physician and they're not familiar with Leva? Like, how can I access it? Is there something I should say to them? Where should I direct them?
On our website, levatherapy.com, we actually have the prescription forms. So you could, some people just email it over to their clinician, or they take it in for the next appointment. Because it is first-line therapy, physicians are very well aware that first-line therapy works if patients are able to access it, and the product is really risk-free. The adverse events associated with it are no different than a woman doing Kegel exercises. So if a physician has any questions, they can certainly call into us, where Mandy and her colleagues are certainly able to answer any questions that they may have. But because it is such benign from a safety standpoint, they really don't push back if a woman asks for it. And it's been so well published.
Congratulations on that, by the
Yeah,
way.
thank you.
Similarly, well, sort of in the same vein, as a patient, if I want Leva, but my insurance doesn't cover it, what can I do to potentially convince my insurance company to cover it?
Absolutely. If you talk to our Leva women's support team, which you will talk to after your prescription goes in, we're happy to connect you with provider support at your insurance plans, or even the name of the chief medical officer at your insurance plan if you would like to advocate for yourself. We have seen patients successfully advocate for themselves and have Leva covered. We also, we will put a prior auth in and can take that through appeals for you. So doing a prior auth not only helps the patients access coverage, it also lets the insurance companies know that there's demand for it. And if we run out of options on coverage from your insurance, you can use your HSA or FSA, and again, take advantage of a zero interest payment plan.
And I think a big theme, not only from this webinar, but from all of Avestria's webinars, have been women advocating for their health.
Absolutely.
And I think too, urinary incontinence is one of those issues that women don't necessarily think it's a problem. They think it happens to everyone, or they don't want to talk about it because of the shame or the stigma, or they feel like it shouldn't really be a problem. So for all of you listening out there, I think, one, if you need it, please advocate for yourself for Leva, but in general, please advocate for your health in general.
That's right.
And then another question. So in one of the slides that Mandy shared, we saw the number of women affected by urinary and fetal incontinence. What if you are a patient or you're a woman who had kids a decade ago or 15 years ago or 20 years ago? Is it too late for you to use?
Absolutely not. Absolutely not. Because the pelvic floor is just a grouping of muscles. And when you go through the trauma of childbirth, they get damaged. When you go through menopause, you lose estrogen and they get loose. So there's always the opportunity to strengthen the pelvic floor again. And you think about the pelvic floor, you think about breathing, right? Like when you breathe in, your diaphragm drops, as does your pelvic floor. When you exhale, your diaphragm goes up, as does your pelvic floor. So when working as it should, you're strengthening your pelvic floor all the way. All we got to do is get that baseline strength back, and then you'll continue to exercise it. So that's really where a lot of women start out. It's that they did have damage from giving birth and they didn't heal on their own. So they go through that 12 weeks of therapy. They get the neuromuscular re-education. Just like when you sprain your ankle and you go to physical therapy, right? You do a series of intense exercises and then you don't even think twice about it. If you do Leva after childbirth, could you need it again as you go through menopause? Maybe, but Leva's there and just get another script from your clinician and can go through another course of therapy. We do, I know we mentioned earlier, have patients as young as 18 and oldest of 91. So certainly women at all different stages of their life can have problems with urinary and fecal incontinence. One of the really interesting things we found is that 30% of our patients that were diagnosed with urinary incontinence, when they fill out their symptoms in our app, have fecal incontinence as well. So it gives you the ability to take care of both conditions at once.
Yeah, and that's huge too. It's an efficient moving for efficiency for women's health as well.
That's right.
I think we have time for one more question. And that is for pelvic organ prolapse. You might want to define it for those who aren't familiar with it. And then 2, will Leva work only for early stage prolapse, or is it one of those things like with women who have had children, it's kind of never too late to start?
No, it definitely, what we're submitting for is early stage pelvic organ prolapse. So if you're breaking through your pelvic floor, like you can physically feel part of your vagina dropping down, then Leva would not be indicated for it. But so it is what they would call stage 1 or stage 2 pelvic organ prolapse.
And then can you just remind our audience what pelvic organ prolapse is?
Yeah, it's generally when your uterus, probably from childbirth, comes outside the vaginal opening. So you can physically feel that you have something in your vaginal canal. And actually when people have really significant prolapse, they don't have urinary incontinence anymore because it's actually blocking, kind of supporting the urethra that becomes very loose when you have urinary incontinence.
Thank you. So I think that's going to conclude our Q&A portion of the webinar, but just as a sum up of what we talked about is 1, always advocate for your health.
Right.
2, talk to your doctor, even if you think something is normal, it may not be normal. And that's where something like Leva can come in and help you out. And also, try and talk to your physicians, talk to your insurance companies, show the interest in these solutions, because that helps entrepreneurs like Eileen, fundraise and keep innovating and really help women's health in general. So thank you for everything you did, Eileen, and are doing. And thank you for also being our guest on the webinar today.
Yeah, I totally appreciate the opportunity to talk to you all today. And the only thing I would add is talk to your girlfriends too, because so many women don't know they have options, and we're best when we work together.